Hello students, today I'll be completing the male reproductive session and then I'll be going to the female reproductive physiology. Hope you are enjoying the classes, you are following the textbook. I feel that Gannon textbook is quite good. You can follow that textbook and hope you are all keeping safe. Now the corona situation is very bad and hope you are all keeping alert and taking all precautions so that we can hope for a better future. So, sharing my screen, we will be, last time we had been in the male reproductive system, the spermatogenesis. So, the learning objective today will be the factors modifying spermatogenesis and the male hormones, the testosterone, its biosynthesis, function, and the regulation of secretion, and finally some abnormal testicular function in brief. Now, spermatogenesis, as we have said, that the spermatogonium, which is present right from birth. Now, initially during the mitotic division in the prenatal life, they give rise to the spermatogonium A and B, where A is being reserved for the self-renewal, and it is the B type of spermatogonium which really enters into the spermatogenesis. And we have said that from the type B spermatogonium to spermatocyte, there are several mitotic divisions, so that from one spermatogonium, at least 16 primary spermatocytes are formed, and this formation of spermatogonium in its state remains for 18 days, whereas 23 days as primary spermatocytes. Now, so this 42 days of a spermatogenesis is in the from the spermatogonium to spermatogonia A and B, and subsequently to the primary spermatocyte. Now here the spermatogenesis is stopped till puberty. So it is being kept abated till puberty, when it enters the first reductional division, the first meiotic division, to form the second spermatocyte. The lifespan is only 1 day. Soon it divides to form the spermatocyte by meiosis II. Now then, from spermatids to the spermatozoa, the matured spermatozoa, by the process of spermiogenesis, we have already discussed it, takes about 8 to 10 days. So it is about 50 days that spermatogonium from its birth to the maturation and release as spermatozoa is about 50 days. And then it remains in epididymis for further maturation and capacitation for another 12 to 26 days, so that a spermatogonium changes into 64 spermatozoa in a span of about 74 days. Now then we are coming to the factors affecting spermatogenesis. The most important factor affecting spermatogenesis is the endocrine environment. Temperature is also very, very important, and there are few dietary factors, especially the vitamins, which keep the health of the spermatozoa. And the radiation exposure, smoking, alcohol, and infectious disease like mumps or orchitis, they all decrease the spermatogenesis. Now, so the hormones necessary for spermatogenesis is in the stage of proliferation, that is spermatogonia, when it divides again and again, up to the primary spermatocyte, it is mainly the follicle stimulating hormone which helps in the process, along with growth hormone which gives the metabolic aid. Now, from the puberty, when it changes from primary to secondary spermatozoid and subsequently, it is the testosterone and growth hormone which is important for the reductional division as well as maturation. And subsequently, the transformation from the spermatid to spermatozoa is definitely the testosterone has an important role, and estrogen probably it has a probable role in the stage of transformation. So coming to the hormonal environment. So the first hormone I must say is the luteinizing hormone from the anterior pituitary, which stimulates the Leydig cells to secrete testosterone. Now, testosterone is the hormone which is the main male hormone for the spermatogenesis as well as for the male type of behavioral pattern, the secondary sexual characteristics, and all the male characteristics is attributed to the testosterone, and it mainly helps in development of germ cells in the post-pubertal stage. Now, FSH is also another important gonadotroph from anterior pituitary, which stimulate the initial phases of mitosis in spermatogonia, as we have discussed. Till the testosterone comes in, it is the FSH which helps in initial phases of mitosis. And another very important function is the development or stimulation of the Sertoli cells. And as we have already discussed, Sertoli cell is not only the nurse cell or the mother cell for providing glycogen for the maturing sperm, but it also provides the blood-brain barrier, very important barrier, which inhibits the immune attack on the spermatids, as well as the spermatozoa cannot mix with the bloodstream to increase the autoimmune activity, to stimulate the autoimmune activity in blood. Besides, the Sertoli cells also has several secretory activities like androgen binding protein, several growth factors and cytokines, and also it has the hormones like aromatase or 5-alpha reductase, the enzymes, sorry, which will help in the production of estrogen and dihydrotestosterone, which are also very important in subsequent development. Then estrogen, as we are speaking, it is produced mainly by the Sertoli cells and very small amount in Leydig cells by conversion of testosterone to estradiol by the enzyme aromatase, and probably helps in spermiogenesis and modulates the testosterone level. And last but not the least, because we have seen that growth hormone right from the beginning to the end, it is the growth hormone which is regulating the metabolic activity and promotes the spermatogenesis. So the hormonal environment is definitely a very important environment. Here we see some interaction between the Leydig cell and the Sertoli cells. Leydig cells being stimulated by the luteinizing hormone from the anterior pituitary. It acts by the GPCR, G protein related receptors, and GS, the stimulatory one, activates the adenylyl cyclase mechanism, stimulates the activity of cyclic AMP, which in turn increases the activity of protein kinase A. And this increases the new protein synthesis in the nucleus, and these proteins are actually nothing but the enzymes which converts the cholesterol into testosterone. We'll come to the testosterone biosynthesis. We'll know the enzymes which are being produced due to the LH hormone stimulation of the Leydig cells, and that will provide the testosterone. This testosterone is the only hormone or factor which crosses the Leydig cells to enter into the Sertoli cells. It definitely enters into bloodstream as well. This testosterone, in presence of aromatase enzyme in Sertoli cells, is converted into estradiol, which again comes back to the Leydig cells. And there are several growth factors also produced by the Sertoli cells. So Sertoli cells are being stimulated by the FSH, which via the same pathway, that is the stimulatory G protein to the adenyl cyclase, cyclic AMP activity, increasing the protein kinase A and the new protein synthesis. Now, of the other new proteins, we have said the androgen binding protein is there, Mullerian inhibiting factor was there, and there was also inhibin, which regulates the secretion of FSH. So, the Sertoli cells and the Leydig cells, they are being very closely interrelated, and this we have taken from the Boron book, textbook of physiology. The diagram is very nicely depicting how is the interrelationship between the Sertoli and the Leydig cells. Now then, coming to the temperature, this is also very, very important. We find that the scrotum has to maintain a temperature around 35 degrees centigrade, lower than the body temperature. Now, how this can be provided? Now, the site of testis we know is scrotal sac outside the body, abdominal cavity, and definitely that is a bit cooler, and we should, especially because the scrotal skin is very thin, corrugated, it have very little subcutaneous fat, and it is very rich in sweat glands. So whenever there is an increased temperature outside, there is sweating, evaporation, and that takes away the heat from the cutaneous blood. And because of the absence of subcutaneous tissue, we see that temperature of the scrotal sac is kept very low. Then the countercurrent system of heat exchange, will come to this, and dartos muscle. There are two muscles, dartos and cremasteric muscles. They buffer the outer temperature, outer environmental temperature. They contract in cold and relaxes in hot weather, which also keeps the scrotal sac cool. Now, the blood supply of testis we see is the single testicular artery, and there is a plexus of vein from the testicular vein, which forms a plexus of vein, which is known as pampiniform plexus. And this artery and the vein forms the countercurrent heat exchange. So here we see that the testicular artery, this is the testicular artery, being fully surrounded by the pampiniform plexus of the testicular veins. And here we see that if the temperature here is around 37 to 37.5 degree centigrade, which is the core temperature, then as it enters into the scrotal sac, as it is exposed to the lower temperature, it starts losing heat. And this heat is taken away by the venous system, the venous plexus surrounding the entire artery. And this venous plexus takes the heat and goes away from the scrotal sac. So when the arterial blood entering at 37 degree is coming down to the scrotal sac, the temperature becomes 35 degree because it continuously loses heat, and that is being taken or absorbed by the pampiniform plexus, which is surrounding the artery. So when it reaches the testis at the bottom of the scrotal sac, we find that the temperature is around 35 degrees. And as the veins, this pampiniform plexus all around the artery is going up, it is taking away the heat with it. From lower to higher temperature, as it is being exposed, it absorbs the heat and takes away the heat out of the scrotal sac. So this is the very efficient countercurrent heat exchanger, which also helps to maintain the temperature of the scrotal sac. Next, coming to few vitamins, of which vitamin B12. What is vitamin B9? It is nothing but a folic acid. All we know that they maintain the DNA and RNA synthesis and helps to promote the healthy sperm in the seminiferous tubule. About vitamin A, we can say that it helps in mainly the differentiation, spermatogonial differentiation A and B, and subsequent differential divisions. And vitamin E and C is mainly the antioxidants. They prevent the oxidative stress to the very delicate sperms and the ROS related activities, that is the reactive oxygen species. These are all, this lipid peroxidation, these are all providing oxidative stress to the sperm, and they are being relieved by vitamin E and C. So these are very few important factors which are promoting the spermatogenesis. Next, we are coming to the functions of Leydig cells. We all know it produces the high levels of testosterone. 5 milligram per day in adults. In adults, it's about 5 milligram, which is being secreted. But don't confuse with a plasma testosterone level. That is about 5 to 6 nanogram per day, per ml, nanogram per ml. But total secretion of testosterone in Leydig cells per day is about 5 milligram. Then there are the enzymes aromatase and 5-alpha reductase, which directly produce estradiol and dihydrotestosterone, though in very small amounts. And these dehydroepiandrosterone, androstenedione, and the progesterone 17-alpha, these are all the precursors of the testosterone, which we are subsequently coming. So testosterone, as we all know, have in its inner core the cyclopentanohydrophenanthrene ring. This ring you are all being very acquainted with. Just see the positions 1, 2, 3, 4. This is the 5th position, this is the 10th position, this is the 13th position, and this is the 17th position. This 3rd and the 17th position is very, very important for the androgens. And so subsequently coming to the testosterone hormone, as I was telling you, in the 3rd position there is a oxo or keto group present, and in the 17th position we have an hydroxyl group along with a methyl group present in the 13th and the 10th position. And it is having the hydrogen ion, 3 positions it is having hydrogen ion, but at the 5th, 6th position we see it is being not completely saturated. So the double ring is persisting. This is the structure of testosterone. And when testosterone is converted into estradiol by the aromatase enzyme, we see that one methyl group is lost. It is being methylated at the 10th position, and the keto group is changed into hydroxyl group at the 3rd position. And in the 7th position, the hydroxyl group remains, and in the 13th position also, the methyl group is present. This is the structure of estradiol due to the enzyme aromatase. And this is the dihydrotestosterone, where we find the complete testosterone structure is maintained. Only there is reduction, that is the hydrogen is added at the 5th position. So it is the 5-alpha reductase. The enzyme is 5-alpha reductase, which adds the hydrogen group at the 5th position, and so it forms dihydrotestosterone. So these are the 2 potent congeners which also have effect in the male body. So this is the testosterone biosynthesis. This picture is from the Boron textbook of physiology. You can this diagram is a bit small, so you can refer always to that text. Now here we find that from the cholesterol only, which is in the mitochondria, in presence of side chain cleavage enzyme, that is the desmolase, we find the pregnenolone is formed. Now this pregnenolone to progesterone, or 17-hydroxypregnenolone to this entire enzyme is nothing but the 3-hydroxysteroid dehydrogenase. 3-hydroxysteroid dehydrogenase. So here we find that always there is a change in the 3rd position. That is, the hydroxyl group is replaced by keto group. In all this compound, see, the hydroxyl group at 3rd position is being changed into the keto group, right? Now we find that the enzyme which helps in the conversion of pregnenolone or progesterone to the 17-alpha hydroxy, that is the hydroxyl group is added in the 17th position, is 17-alpha hydroxy pregnenolone or progesterone. Now the next hormone is the again desmolase, because this side chain has to be removed. This side chain has to be removed. So here from on this onwards, we see that they become 19 carbon atom, because 2 carbon side chain is being removed. So from 21 carbon atom, we find that this becomes 19 carbon atom, and DHEA, this is also a very potent androgen, dehydroepiandrosterone. This is secreted in the adrenal cortex also, and androstenedione, this is also present in the adrenal cortex. And then from here, by the 17-hydroxysteroid dehydrogenase, there is interconversion. This is interconvertible into androstenedione and into testosterone. Now, here we find that in 3-beta hydroxysteroid dehydrogenase, the hydroxyl group has been changed to keto group. Now, here, but we find that the opposite reaction is also happening, that this keto group at 17th position is being changed into hydroxyl group. So, this is interconvertible. That is, hydroxyl group is replaced by keto group, or the keto group is being replaced by hydroxyl group. And the enzyme here is 17-hydroxysteroid dehydrogenase. And subsequently, very small amount of 5-alpha reductase, which is present, changes the androstenediol to androsterone and testosterone into dihydrotestosterone. But more of them, which is present in the Sertoli cell, is the aromatase enzyme, which converts testosterone into estradiol. We have seen the structural change, and it is the androstenedione which is converted into estrone. But this aromatase enzyme is not only present in the Sertoli cells, it is present in many of the peripheral tissue, very importantly, the adipose tissue, the bone, the skin and liver, and very importantly in the brain. It is in the brain, it is in the males also, that is the estrogen, which controls the libido of male individual as well. So peripherally, it is this aromatase enzyme is present in adipose tissue, bone, skin, liver and brain. And the 5-alpha reductase is present in prostate and also some gonadal tissues, and definitely in the Sertoli cells. So this is in very short the testosterone biosynthesis in the Leydig cells. And the adrenal androgen synthesis, you all know the same pathway, pregnenolone, progesterone, 17-hydroxyprogesterone. Now from progesterone, there is the 11-deoxycorticosterone going for the aldosterone pathway, and 7-alpha hydroxyprogesterone gives the pathway for cortisol as well as for the androstenedione, that is the androgen in the adrenal cortex, and that definitely changes by 17-beta hydroxy progesterone into the 17-beta hydroxysteroid dehydrogenase. It changes into testosterone and subsequently into the estradiol. But estradiol, we see it is not in the adrenal cortex, it is in the peripheral tissues, as we have already said. Now the effects of the testosterone metabolites, dihydrotestosterone and estradiol, besides the testosterone. Now testosterone has main function in the muscle mass, typical male torso, the skeletal growth, the height of the male individual, very importantly spermatogenesis we have already discussed, and about the sexual function. Dihydrotestosterone is mainly concerned with the secondary sexual characters, the facial and body hairs, acne, the scalp hair loss, because in the scalp there are a large number of DHT receptors, androgen receptors, and they under the action of DHT, specifically there is male type of baldness, male type of hair loss, alopecia areata, due to male type of hair pattern comes from DHT. Then the prostatic growth, as well as there is the growth of the external genitalia, which is we call the masculinization, that occurs under the influence of DHT. And estradiol, the bone, the epiphyseal closure is influenced by estradiol, breast tissue, and very importantly, the action on the brain to maintain the libido. That is also very important. Now coming to the function of testosterone in brief. Now in the Leydig cells, this testosterone once formed, it comes to the blood circulation, and peripherally also by 5-alpha reductase, it is converted to 5 to 10% is converted into dihydrotestosterone. Both testosterone and dihydrotestosterone acts on the androgen receptors, and testosterone, the functions are in the natal life. We have seen that the development of the Wolffian system, where MIF inhibits the Mullerian system. So the male phenotype formation in the prenatal and natal life is due to the testosterone hormone. Then spermatogenesis, which we are discussing, and also regulating the gonadotrophin secretion by the negative feedback on the pituitary as well as hypothalamus. Dihydrotestosterone, on the other hand, have the external virilisation, that is the external and accessory male sex organs mature under the influence of dihydrotestosterone, both natally and postnatally. And postpubertal, the sexual maturation, secondary sexual characters at puberty is under the influence of dihydrotestosterone. This dihydrotestosterone is about 3 times more potent than the testosterone, and it is quite stable than testosterone. So in the dihydrotestosterone, actually we have an amplification pathway. So here testosterone 5 to 7 milligram per day produced in the Leydig cells under the influence of GnRH from hypothalamus and Leydig cells from the anterior pituitary. Now the direct pathway where testosterone directly acts on the androgen receptors, mainly on the muscles, on the spermatogenesis, on the growth spurt, as well as on the sexual functions. Now 5 to 10% under the influence of 5-alpha reductase peripherally as well as the Sertoli cells forms the dihydrotestosterone. This we see that there is an amplification pathway because it's more stable and at least 3 times more potent than the testosterone. The receptors are present in prostate and skin, where the 5-alpha reductase is also present. They also act through androgen receptors, and we have seen that they have mainly the external virilization effect and the secondary sexual characters. Estradiol, only 0.2% by the aromatase enzyme, mainly in the Sertoli cells or in the peripheral cells, act via the estrogen receptors. Most important function is the modulation of the testosterone activity, as well as it is the male libido is being maintained. So here are the effects of testosterone on the skin, on the sex organs. In the bone marrow, the red cell production is very important, and in brain, we see it increases sex drive, improves mood, and important is memory function. Loss of testosterone leads to loss of memory function and the self-confidence. And the bone mass density is increased due to the presence of the testosterone. And definitely the sperm production and erectile function is also due to the testosterone. So here is a list of the testosterone and dihydrotestosterone. You can go through this. Now the plasma level of testosterone, as I was telling you, is a nanogram per milliliter of blood. During the prenatal life, we see there is a testosterone burst, and under its influence, not only there is maturation of the testis and the male phenotype, but also there is descent of testis. From the 12th week up to the 30th week of gestation, under the influence of testosterone, there is descent. And then there is small postnatal spurt at about 2 to 3 months. This is due to the activation of HPA axis, and this also helps in the testicular descent if that does not occur during the prenatal life. Then testosterone is kept very low due to the high sensitivity of the hypothalamus pituitary axis, and subsequently at puberty there is a very high rise secretion by the Leydig cells under the influence of the LH hormone, and it remains till the almost 7th decade that it is being maintaining the adult level of about 5.5 to 6 nanogram per ml till there is a descent of the plasma testosterone level. Now finally, about the regulation of the testosterone secretion, we see that the Leydig cells are secreting the testosterone hormone by the influence of LH from the anterior pituitary. So hypothalamus secretes gonadotrophin, under the influence of which LH and FSH are being secreted. This LH helps in the maturation of Leydig cells for the secretion of testosterone, whereas FSH, it keeps the health of Sertoli cells, which is secreting the aromatase enzyme for the conversion of estradiol and also the inhibin. Now testosterone, we see that it has a negative feedback both on the entry pituitary as well as in hypothalamus, whereas estradiol in male shows inhibition, negative inhibition, only in the pituitary level as well as inhibin. And inhibin is mainly inhibiting the FSH secretion because it is controlling the health of the Sertoli cells. And the estradiol and testosterone is definitely controlling the secretion of both LH and FSH. So this negative feedback keeps the hormonal level under control. Now, a few words about the estrogen in male reproduction. Most important is it regulates the male libido, because in brain there are large number of aromatase enzyme which converts the testosterone into estrogen and helps in male libido. And there is a very subtle balance between the estrogen and the testosterone hormone. More of estrogen will have a detrimental function on erectile function as well as in the sperm production. So it is mainly the regulation or modulation of the testosterone hormone which is the primary function of estrogen in the male body. Now coming to certain abnormal testicular functions. One is crypt orchidism or undescended testis, then male hypogonadism, then anachoidism, and lastly the erectile dysfunction. Now, normal descent of testis, this is the original position where the testis is being formed, and it is through the inguinal canal, the inner ring, the outer ring, it comes out into the scrotal sac. And undescended testis, it may remain intra-abdominally near the internal ring, in the inguinal canal, near the external ring. Now, at the mouth of the internal ring, it comes about 12th weeks of intrauterine life. Then rapid descent by 25th week, it comes near the external ring and descend to the scrotum. So these are all the positions of the undescended testis, and this is the ectopic testis. Now, so this crypt orchidism is a condition in which both testes fail to descend from abdomen to scrotum, and it's a very common developmental anomaly in male, and 89% of the untreated crypt orchidism will develop azoospermia and subsequently infertility. And there is fourfold increase in the lifetime risk of developing testicular neoplasia, the malignancy. And the treatment is orchidoplexy, that is replacement, surgically replacing testis to the scrotum, but that should be done before puberty so that the complete azoospermia does not set in. But this does not guarantee the fertility, because the sperms which are being lost can not be regained, and the chances of malignancy still remain increased in the individual with crypt orchidism. Now coming to male hypogonadism, it may be due to the hypothalamic dysfunction, which is known as Kallman syndrome, or pituitary dysfunction due to the pituitary tumor. Now here we see that the LH or FSH secretion is low, or GnRH secretion is low, so also the LH FSH secretion is low, but the along with that the testosterone is low. So this is called secondary hypogonadism. Secondary hypogonadism, secondary to the hypothalamic dysfunction or pituitary dysfunction. Kallman syndrome is a syndrome where we have typically anosmia, because these GnRH neurons are being formed from the nasal placode, and so there is dysfunction in both the normal development of the nasal neurons as well as the GnRH neurons. And besides that, there are several causes of the hypothalamic dysfunction, like obesity, like hyperprolactinemia, that causes the hypothalamic dysfunction. Pituitary dysfunction, this is also a hypogonadotrophic hypogonadism, and here the Kallman's, the obesity, hyperprolactinemia, all are being there, but definitely important is the pituitary tumor, which decreases the secretion of LH and FSH. And the primary cause of hypogonadism is decreased testosterone secretion independent of the hypothalamic or pituitary function. Here we find that the LH or FSH level is high. The one very common example is the Klinefelter syndrome, which is an chromosomal anomaly where we find that XXY is where the female hormone is predominant, female chromosome is predominant. So here we find that there is definitely primary hypogonadism. Then undescended testis is another cause of hypogonadism. Primary mumps orchitis, then injury or radiation to the testis also will cause the primary hypogonadism. Now, this anax, that anachoidism, is due to usually deficiency of Leydig cells. So they have the masculinizing features and they are usually infertile. Now, lastly, about the erectile dysfunction, where we see that this is the testicular shaft, where we see that there are corpus cavernosum. Corpus cavernosum, that is, the penis has complex web of blood vessels, corpora cavernosa, that are organized much like sponge. And there is a central artery, which is known as the cavernous artery, and the spaces around them allows the blood to percolate from the artery into these spongy spaces. And when this spongy spaces, they become engorged with blood, the penis becomes erect. And here we see that when the cavernous spaces are being closed or they are not engorged with blood, we see that the penis remains in flaccid state. Now, this erection is mainly due to the parasympathetic innervation. Due to the sexual stimulation, the parasympathetic nerves get stimulated and they causes the smooth muscle of the sinusoids and arterioles to relax because there is secretion of nitric oxide. Nitric oxide is a potent smooth muscle relaxant, and this nitric oxide causes expansion of the sinusoidal space and increase the arteriolar blood flow. So the arteriole, they dilate and there is increased arteriolar blood flow, and that goes into the sinusoidal space and there is expansion. And what happens to the veins? They get compressed by the subtunical vessels, they get compressed by the engorged cavernosa, and at the same time, due to the nitric oxide, they get collapsed because the smooth muscles are relaxed. So veins are compressed and collapsed, and at the same time, the corpora cavernosa gets engorged due to the arterial blood. Arterial flow increased, venous flow decreased. So there is stagnation blood in the cavernous space, and that causes the erection. And this is the sympathetic activity. Smooth muscle contracts, sinusoidal spaces and the arterioles, they contract. So collapse of the sinusoidal spaces and the decompression of the subtunical vessels leading to the flaccid penis. And there are few main organic causes for this erectile dysfunction. 40% cases we see that they are vascular. Then there are certain neurological and the hormonal causes for the erectile dysfunction. But especially now, the sildenafil is coming into action, which is actually causes the alteration in the nitric oxide metabolism because it is a phosphodiesterase inhibitor, and that causes increased nitric oxide and increased engorgement of the blood vessels. So coming to the summary, we have said about the factors influencing spermatogenesis, the hormones, the gonadal hormones, as well as the gonadotrophs from the anterior pituitary. We have discussed about the functions of testosterone as well as the amplification pathway, the dihydrotestosterone, and diversification pathway, the estradiol, and it is being testosterone excreted from the renal and the hepatic secretion, and about certain important abnormalities of the testicular function. So thanking you, class, for today. Thank you very much.